Finance. Public comment, please.
Madam Chair and Senator Monning, Paul Neprath on behalf of Planned Parenthood Affiliates of California. And we raised some of these concerns and these issues with the OFP stakeholder group, but wanted to bring these to your attention. I think we're concerned about this proposal from a couple of standpoints. One is that the Bixby UCSF Center it's a world-renowned, it's a very well regarded institution that has provided a lot of critical analysis, evaluation data. They've done a phenomenal job in California on behalf of family planning, and in particular on the Family PAC program. Their analysis, the evaluations have led to many policy and clinical changes that have improved family planning services in California, to the extent that California probably has arguably the best family planning program, state family planning program in the country with regard to lowest rates of unintended pregnancy, in particular teen pregnancy rates. So we want to just acknowledge that there's been a tremendous amount of work that's been done over the years, and that they have lent their tremendous expertise into making these things better. So I think we're just concerned about losing that connection to that expertise, losing the value that they would bring. We understand what the department is proposing. We understand there's a cost savings in going in this direction. We're hopeful that this is not one of these penny wise and pound foolish conclusions, but we did want to raise some of these issues to you. We appreciate it. It's an open item. We'll be happy to provide further detail to you in writing as this item progresses. Thank you.
Thank you. Next witness.
Chair and members, Kathy Mossberg, representing the California Family Health Council, the Title X federally funded family planning clinics in the state of California. We would just echo the comments of Mr. Neprath with PPAC. And I think just as someone who's been around for basically the duration of the Family PAC program, it is an incredibly successful program, draws down a ton of federal dollars. And part of that success has been to have this outside entity doing evaluation and allowing for us to see the data and make changes in the program. It also helped us in really lean years budget-wise defend the program. Certainly that 9-to-1 match is incredibly helpful, but we had to make sure that people understood the program was effective and show that data. Bixby folks have been able to help us do that. So we appreciate you're holding it open, and we'll continue to have conversations.
Thank you very much, and we will hold that item open. Issue 13, the dental fiscal intermediary turnover takeover.
So this is a request for 3-year expenditure authority to support the work equivalent to 3 positions and the contractual services associated with the workload of the conversion of the current fiscal intermediary contract into the new proposed split between administrative services and claims processing. In terms of the improvements, one of the reasons we went in this direction is we did think it would be better for vendors to be specialized and focused on the different elements. That is how it works for the rest of the Medi-Cal program. Dental was the only place where you had sort of the administrative services being done by the same entity doing the claims processing, and we think that this will enable a better focus on those business practices and help support the ongoing work the department is doing in trying to improve the Denti-Cal program.
Can you let us know when you plan to announce the awards of the 2 dental fiscal intermediary and the administrative services organization contracts?
Trying to see if I know that.
Okay.
Let me follow back up. I don't want to say something wrong and
have people celebrate then they. So you'll get back to the committee.
Yes,
I'd appreciate that. Great. LAO, Finance. Any public comment on this item? Seeing none, I would entertain a motion.
So moved.
Thank you. Call the roll, please.
Mitchell?
Aye.
Monning?
Aye.
Thank you.
Your request is out, 2-0. And you'll get back to us on the award recipients.
Yes.
Moving on to issue 14, the Robert F. Kennedy Farm Workers Medical Plan, SB 145.
Sure. So this request is related to the establishment last year of the program for the RFK plan to have us pay for claims over the amount of $70,000. So we are asking for 1 position for 5 years, as well as a one-time investment for the IT and accounting functions.
LAO, Finance. Any public comment on this item? I'll entertain a motion to approve.
So moved.
Call the roll, please.
Mitchell?
Aye.
Monning?
Aye.
Item 15, hospital quality assurance fee extension. And the LAO is going to present on this one. Excellent.
This is a stakeholder proposal from the California Hospital Association. The Hospital Association requests that the subcommittee consider trailer bill language to extend the sunset date of the hospital quality assurance fee from January 1, 2017 to January 1, 2018. While we at the LAO do not have a position on this particular stakeholder proposal, we recommend an extension of the hospital quality assurance fee in concept during this legislative session in order to maximize the benefit to the general fund as well as to the hospital industry. We also note that there's a recently finalized rule from the federal government that could require changes to how the fee is currently structured. This rule is just so recently finalized that the department is still working to understand the potential impact of the rule on the fee, but if there was any impact, it wouldn't really come into play until July 1, 2018. So it would be outside of the scope of this particular stakeholder proposal, but just something for the legislature to be aware of when considering any potential extension of the fee.
Thank you very much. Any comment, finance?
The administration has no position on the proposal.
Okay, thank you so much. And we'll hear from public comment. First witness.
Madam Chair and Senator Monning, Barbara Glazer with the California Hospital Association here today with this request. We consider this a backup measure. We are sponsoring an initiative that will be on this November's ballot, but should that not pass, and that initiative would make the fee permanent, but should that not pass, I think it's important that we have the fee in place so that we don't lose any time next year in putting together, in other words, keeping the fee going. So we would urge your favorable consideration of this request.
Thank you. Next witness, please.
Mira Morton here on behalf of the California Children's Hospital Association, and we're also in support of extending the quality assurance fee.
Thank you.
Megan Loper on behalf of the District Hospital Leadership Forum, ditto.
Carrie Thomas on behalf of the California Association of Public Hospitals and Health Systems. We're in support of this request.
Lisette Shore on behalf of Peach Hospitals and the Alliance for Catholic Healthcare in support.
Kelly Hardy with Children Now and the California Children's Health Coalition in support.
Eduardo Martinez, California Medical Association in support.
Thank you very much. And we'll hold this item open. Item 16, Medi-Cal payment reductions, rates, and access. We're on page 53 of the agenda.
Sure, so you had a couple of questions for us related to the monitoring that we do. So we evaluate fee-for-service access in several ways. We have the quarterly access reports that were contained as part of the approval of the AB 97 reductions in our state plan. That covers 4 key measures focused on utilization, and we've published 11 of those quarterly reports, and we'll be publishing the third quarter of 2014 later this month. We also have annual access reports that cover a broader array of measures, including things like avoidable hospitalizations, the visits to physicians, and ED rates. The data that we use really pulls from various sources, including our eligibility data, our claims data, the vital statistics, the OSHPD data files that we match with our data files, as well as looking at any calls to our various phone lines about concerns about access, as well as using information from the California Health Interview Survey. In addition to the standardized reporting that we also do ad hoc analyses when providers or other stakeholders indicate that there could be an issue, and so we request data from those particular providers and do analyses at those times. With respect to the access monitoring plan that are now part of the federal rule that was published last November, that the deadline for submission of those plans is October of this year, so we're currently working through what we would like to change in terms of the access monitoring. So the access monitoring plans we have now, essentially those would morph into the required ones under the federal rule. It really does require a significant increase in the number of provider types that would be being tracked, because certainly the ones we have now are really related just to the AB 97. This is broadly monitoring access beyond that. and would be looking at rate comparisons between Medi-Cal and other types of payers. So we will be releasing that hopefully probably this summer for public comments. We're required to, but also would like public comment on what the plans would look like moving forward so that we can then meet that October deadline.
LAO? Finance? Public comment, please.
Thank you, Madam Chair and members. Michael Arnold here representing two clients, the California Clinical Laboratory Association and the California Dialysis Council. Let me start with clinical laboratories. They are in a very unique situation. They were hit by the AB 97 10% cuts. Then the next year, the legislature passed AB 1494. Most people are unaware of this. AB 1494 did two things. First, it placed an additional 10% cut on laboratories for a total of 20%. Secondly, it required the development of a new methodology to determine reimbursement rates for laboratories based upon the lowest amounts paid by other providers. By other payers. Therefore, every year since that time, clinical laboratories submit data to the department. The department crunches these data, comes up with a rate for reimbursement for approximately 400 laboratory tests. The tests rates have been significantly reduced as a result of this to be along the same lines as the average of the lowest rate paid by other payers. Once they find that rate, then they reduce that rate by an additional 10% because of the AB 97. At the present time, however, because of the antiquated computer system that the department has, laboratories are being asked to pay a recoupment for the 10% cut in AB 1494 over and above the AB 97 cut, which wasn't put in place in time to capture all those savings. Then an additional recoupment for the new rates that came up as a result of the new methodology, because they weren't put in place on July 1 of 2015. And now we're coming up with a new rate, which likely won't be put in place on July 1 of 2016, so there'll be a third recoup. The bottom line is laboratories don't know what they're getting paid. They have to go back and try and figure it out. The department tries to figure it out. Everybody is going to, so it's time for a true up. We need to, and we're requesting that laboratories be forgiven for all of the various recoupments, and just let's start afresh and just pay the laboratories based upon the average of the lowest rate paid by other payers, reduced by the AB 97 10%, which is still about a 30% reduction over where they used to be before AB 97. So that's our request. And in addition, if you can see your way clear to remove the AB 97 cut, that would be helpful as well. But at the very least, for laboratories, we're asking that those recoupments be eliminated. We think that's only fair, and we think it'll probably work out to be cost effective based upon the avoidance of all of the back and forth issues that otherwise will exist. Secondly, on behalf of the California Dialysis Council, I'll be brief. We have a ticking time bomb out there these days. In our urban communities, particularly communities of color, where hypertension and diabetes are so prevalent, we have a very, very high rate of ESRD, end-stage renal disease, where the kidneys are no longer functioning. We also have a high rate of Medi-Cal-only patients. So two things are happening. We don't have enough slots for dialysis patients. A dialysis clinic is considered full when they run 3 shifts, basically 5 a.m. to 7 p.m. They're now running 4 shifts in these urban areas, 5 a.m. to about 10 or 11 p.m., which is very unhealthy for the patients that aren't working patients that are, that's all they can get. Also, patients are not able to get out of acute care facilities. So we have Medi-Cal patients who are dialysis patients. They have other comorbid conditions. And the discharge planner in the hospital says, let's find a spot for them. The dialysis clinics are full. They have other ambulatory patients. So they're saying, we can't take those. That's costing the Medi-Cal program many, many thousands of dollars because these patients are staying in the acute care facility when they could be better served in a non-acute care facility. So Our request is that it's time to repeal the 10% AB 97 rate cut for dialysis clinics. We think we could do that based upon the numbers we've seen for about $7 million a year. And we think it would address what has otherwise been a chilling impact on the placement of new dialysis facilities in California. So number one, companies are not coming here anymore. And number two, if they are, they're not going into these areas where there are high, pure Medi-Cal beneficiaries. So thank you for your time.
Thank you very much for your testimony. Next witness, please.
Madam Chair and members, I'm Bill Barnaby here on behalf of two clients. The first is DaVita Dialysis, and I won't repeat what Mr. Arnold said, but the problem with the rate cut is that it inhibits the ability to plan new facilities. There's not a revenue stream that supports that, and we're working towards a capacity crisis, and we need to at least restore the 10% cut for the small cost of $7 million general fund. The second request is on behalf of the California Medical Transportation Association, non-emergency medical transportation. Most of their patients, most of their users are dialysis patients. And these are people for whom a physician has certified that their medical condition doesn't allow them to ride in a bus or car to and from medical treatment. So they're not getting the access that they need because the 10% cut has decimated the NEMT network. We need to restore that, and the cost is, again, small. It's in the neighborhood of $4 million general fund a year, and we think these two items are generally often considered as budget dust, but they're very important to the people who use them, so we would urge restoration of the 10% for these two services. Thank you very much.
Thank you, Madam Chair. Eduardo Martinez with the California Medical Association. Echo the prior comments about the concerns about low rates and the impacts of the AB 97 cuts. Also just wanted to thank you and your committee for continuing to look at this, continue to make sure that, access is maintained, particularly with what most folks are acknowledge are unacceptably low Medi-Cal rates, but also to encourage you to focus the attention about once cuts are passed, how do we implement them, and are they implemented in a way that discourages providers from participating? And one issue which is not reflected in your analysis that we just became aware of this week that I wanted to bring to your attention. In 2010, the legislature cut services for radiology services essentially to 80% of Medicare rates. It took CMS several years to approve this cut. And once they did, DHCS began, proposed a plan to recoup the cost of this cut over 2 years. We reached out to them early and asked them first for a forgiveness. That was we were told that was not possible. But then we asked them to work with us on how they implement the cut, but most notably to take the cut out. This is a clawback cut, to take the cut out in segments and not all at once. And they assured us, in fact, we have it in writing, that this cut is going to be recouped in 20% increments, right? So every claim that the provider gets, 20% off, 20% will be taken off the top. We've been informed this week that, in fact, they are not doing that. In fact, they are recouping 100% of the claims made until the clawback is fully paid back. So one example, we've heard an obstetrician in LA County. She does a number of high-risk pregnancies, so she has a lot of these radiology service claims. She's being told that she will not be paid any claims until her bill of almost $400,000 is repaid back to Medi-Cal, in which case she's just simply not going to be able to continue this and is probably going to have to shutter her doors, in which case we don't get those providers back. So again, I know we've talked a lot about this, about access in Medi-Cal. Appreciate all the good work of the committee and the legislature, but continue to be diligent about how the cuts impact access to care, not only before but after they're passed.
Thank you so much. Next witness.
Kathy Dressler with the Children's Partnership, and on behalf of the Children's Health Coverage Coalition. Our groups remain gravely concerned that there are serious access issues given the very low Medi-Cal reimbursement rates, and would urge the committee to review that. Thanks.
Kelly Hardy with Children Now and the Children's Health Coverage Coalition. Thank the committee for the attention to these issues. I would note that 54% or 5.6 million of all California kids are in Medi-Cal, and so it's imperative that separate adequacy standards be applied for them so that we can know whether a pediatrician is in fact available, and that separate measures are applied to kids so that we know how the kids are doing. If they're folded into overall measures, we don't know anything about how kids are doing. Thank you.
Tam Ma with Health Access, echo Ms. Dressler's concerns.
And we're going to hold item 16 open as well. Thank you very much. Appreciate it. We'll be moving to the final segment of today's agenda, item 4265, Department of Public Health. We have 4 issues before us today. We're going to start with Women, Infants, and Children's Program. Good afternoon. Hit your button. There you go.
Red means go, right?
Yeah, in this committee at least it does, yeah.
My name is Connie Mitchell. I'm the Deputy Director of the Center for Family Health. And in our center, we have 3 divisions. We have Genetic Disease Screening Program, which is later on the agenda. The Women, Infant, Children Program is our 2nd division, and then also Maternal, Child, and Adolescent Health. So Christine Nelson is the division chief for WIC, and she'll be presenting to you on the issues on the agenda.
Thank you very much. Welcome.
Good afternoon. I have my light on there. Thank you. So I'll give a little bit of an overview of the WIC budget and then talk about the 2 proposals that we have. WIC is funded by the U.S. Department of Agriculture through 2 grants. The food grant, which is used to reimburse the authorized stores for the food costs, and also the Nutrition Services and Administration grant, which is used to support the local WIC agencies as well as state operations. We also receive rebate funds from our contracted infant formula manufacturer, and those rebate funds can only be used for food costs. In the budget year, we estimate that we will spend just over $1 billion on food, including federal and rebate funds, and those food costs will support the 1.2 million participants that we see serve every month in the WIC program. In our estimate, we have showed that the participation has been declining over the past few years, and I'll address that in just a moment. And there have also been minimal increases to the average food cost per participant because of inflation and because of a couple of recent changes in our food package. So with the declining participation and a small growth in the average food cost per person, overall total food costs are relatively flat. And also our grant from the USDA is also relatively flat. So we continue to have enough federal funds to fully support the program and have some room for growth. So I'll talk in just a moment about increasing participation, but we do already have food dollars available for that growth. Let's see. In the estimate, as you know, the past few estimate packages, we have broken down our participation by the different categories. So you could see now that what the average food cost is for each category. Infants is our most expensive food category, and with the average food cost there is about $117 per infant per month. And other categories, pregnant, postpartum women, and infants, range from $41 to $57 per month. Our first budget change proposal is to address the increasing participation in children. Children is our largest category because they stay in that category for 4 years instead of a year or less. They make up about 57% of our total population within the WIC program. And while California does have the highest coverage rate of all the states, our coverage rate for children is the lowest. So it's pretty standard in the WIC program that pregnant women, postpartum, and infants is the highest participation category, and then children is the one with the lowest coverage because they tend to kind of age out as they get a little bit older. So that's the area that we want to focus on. Families that are enrolled in CalFresh and in Medi-Cal are adjunctively eligible for WIC, so that's our first area to really go target, to look at those data sets, excuse me, to see where there are children that are in CalFresh or in Medi-Cal but not in WIC, because that's an easy win for us to be able to reach out to those families, understand those communities where they have, thank you, lower co-enrollment rates, and we also want to study those areas that have high co-enrollment rates so that we know what are they doing that's working really well. So in our proposal, we are requesting 2 positions for research scientist positions that will focus on the data linkage and the GIS mapping so that we know where are those communities. And they'll update that data set every year and then rerun that analysis so that we see how we're changing over time. With Medi-Cal adding undocumented children to the program, that's something that will definitely impact us as well. So we want to see over time, and it's not a one-shot deal to do that match. We want to do it every year. And we're also asking for 2 positions, health program specialists, that will really go out into the field with CalFresh to work with our local agencies and our counties to understand what are their enrollment practices, what are the challenges with referrals, and see how we can improve that. Are there systematic things that we need to do? How can we develop targeted outreach strategies as well to address really the reasons for that particular community? Because with California being so large and so diverse, it's not going to be a one-size-fits-all solution for addressing this. Our second budget change proposal is for our project that we call EWIC, which is the project to transition WIC from paper vouchers to EBT. So that project really has 2 parts. Really the simplest part is contracting for an EBT service provider, which will work with the banks and the grocery stores to change that process at the store. But the biggest part that we need to do is to replace the IT system that we use in the states and also state office and in the local clinics, so that we have all the data that we need about the different food items, and also so that we can issue benefits in a different way. So that's our big lift there, is to replace that IT system, which we've had in place for about 20 years. It did. So the good thing about replacing the IT system is that, of course, it's fully federally funded, and we're not building a new system. There are systems already approved by U.S. Department of Agriculture in use in other states. So we will go out to bid to identify what we call a system integrator to bring a system to California, adjust it a little bit to fit the needs of California and make sure that it can hold the capacity, because our caseload, of course, is much larger than other states. And then train our local agencies, our state staff, do all those kinds of things with the change management process to roll it out. So that's the big lift, is getting that IT system in place and rolled out in California. So we have partnered with the Office of Systems Integration to oversee that project for us. And so our BCP is basically to fund their companion BCP, which I think you heard a couple months ago. They're requesting new positions, and so we are basically funding that project for them to oversee the project on our behalf. Very good.
I have a quick question. Yes, on the EBT transition.
Yes.
I would hope that you'll be mindful. We had a major snafu with the CalFresh EBT transfer a number of years ago when was it CalFresh or CalWorks? No, I can't, it may have been CalWorks, when the contracted bank that DSS contracted with was not a California-based bank and therefore didn't have many California branches. The point of sale fee was rather high. And I think it was CalWorks recipients were getting a hit every time they used it at Target or wherever they were using it. And so I'm hoping that as all of our entitlement programs are transitioning over to the EBT system, which is reasonable and fair given new technologies and cost savings for us and reduction of fraud, I would hope that we don't pass those fees and costs on to the beneficiary.